MLT Case Study Series 26 Navigating the Complexities of Systemic Lupus Erythematosus, a case study approach bridging laboratory findings with clinical management in SLE. Introduction. Systemic lupus erythematosus, SLE, is a chronic autoimmune disorder where the immune system attacks healthy tissues, causing widespread inflammation and damage. It can affect the skin, joints, kidneys, and other organs, leading to symptoms like fatigue, joint pain, skin rashes, and fevers. The disease predominantly affects women and varies greatly in severity and progression, with periods of flares and remission. The cause of SLE is not fully understood but involves a combination of genetic, environmental, and hormonal factors. Case Study, Systemic Lupus Erythematosus, SLE, Patient Presentation, Patient, a 29-year-old female. Chief complaints, joint pain, arthralgia, in hands and knees, fatigue, and a facial rash that worsens with sun exposure. Medical history, unremarkable, except for occasional mouth ulcers. Family history, mother has rheumatoid arthritis. Physical examination, vital signs, within normal limits. Skin examination, male rash across the cheeks and nose, butterfly rash, no other skin lesions noted. Joint examination, mild swelling and tenderness in the metacarpophalangeal joints. Laboratory findings, complete blood count, CBC, mild anemia, leukopenia, erythrocyte sedimentation rate, ESR, elevated C-reactive protein, CRP, normal antinuclear antibody, ANA, test, positive at a high titer anti-double-stranded DNA, anti-dsDNA, positive anti-Smith, anti-SM, antibody, positive complement levels, C3, C4, decreased urinalysis, proteinuria and hematuria. Differential diagnosis, rheumatoid arthritis, RA considered due to joint pain, but RA typically has a positive rheumatoid factor and anti-CCP antibodies, which were not present in this case. Dermatomyositis, can present with a rash and muscle weakness, but muscle enzymes, e.g., creatine kinase, are normal in this patient. Sjogren's syndrome, presents with dry eyes and mouth, but lacks the systemic features seen in SLE. Diagnosis, the patient's clinical presentation and laboratory findings support the diagnosis of systemic lupus erythematosus, SLE. The presence of a malar rash, joint pain, specific laboratory markers, ANA, anti-dsDNA, anti-SM, and complement deficiencies are consistent with SLE criteria. Management, education, on the importance of sun protection and understanding the chronic nature of SLE. Medications, hydroxychloroquine for skin and joint symptoms, NSAIDs for joint pain, and corticosteroids for acute flares. Follow-up, regular monitoring of renal function, blood pressure, and disease activity, with adjustments to therapy as needed. Discussion, for medical lab technologists, understanding the role of specific laboratory tests is crucial in the diagnosis and monitoring of SLE. ANA test, almost always positive in SLE patients, it's a sensitive, but not specific, test. Anti-dsDNA and anti-SM antibodies, highly specific for SLE and can indicate disease activity, especially renal involvement. Complement levels, C3, C4, low levels can indicate active disease and immune complex formation. Urinalysis, proteinuria and hematuria can signal renal involvement, which requires prompt attention. Importance for lab technologists, quality control, ensuring the accuracy and reliability of test results, given their critical role in diagnosis. Interpretation, understanding the clinical context to provide meaningful interpretations of laboratory results. Communication, effectively communicating findings with the healthcare team to aid in timely and accurate diagnosis and management. Thank you. Please subscribe for more videos.